Hi, welcome. I'm Scott Succo, the Executive Director of the Liver Coalition of San Diego, and we've got a great final episode actually in our Liver Q&A webinar series this year. And we're very excited tonight to have it on liver cancer with a fantastic presenter. But before we get to the presenter, who will be introduced by our board president, I wanted to thank our sponsor from Dynavax, Carl. Hey, Carl.
Hey, Scott, thank you so much. It really has been a pleasure to sponsor this series. It is so great to see education like this disseminated out into the community. We are very, very excited at Dynavax that our new 2-dose 1-month vaccine for hepatitis B is actually placed really well in this talk, just because one of the contributing factors or causes of liver cancer is hepatitis B. And in this time of being very concerned with treating conditions, viruses that have no cure, hepatitis B certainly fits in that category. So we really are just so excited to be sponsoring this series, and especially tonight with Dr. Frenette. So thank you, Scott, for this opportunity. And Dr. Frenette, I'm looking forward to your talk. Thank you.
Thanks, Carl. Before I introduce our board president, I want to remind folks that during the presentation, if you've got questions that pop up, use the chat feature or question feature. Those will come to me, and then I will put those together, and at the Q&A section at the end, share those with Dr. Frenette. At this point, I'd like to introduce our board president, Terry Cunningham. Hey, Terry.
Hi, Scott. And I'd like to welcome everybody that's tuning in to this webinar. It is the last in our series this year, but we will have more starting up again next year. And we are providing these in order for people to learn more about their livers and the diseases that affect them. This is brought to you by the Liver Coalition of San Diego, and the Liver Coalition is a nonprofit organization that was started a few months ago after the American Liver Foundation closed their district offices. We felt as though we needed a presence here in San Diego where people could get information, ask questions, and be informed. And that is what this series is about. If you have further questions, you're more than welcome to go to our website, Liver Coalition San Diego, and type in your questions, and we will try to get back to you as soon as possible. This session is going to be on liver cancer, and Dr. Frenette is going to be presenting, and she always does a very interesting presentation. So I hope you enjoy it. All of the other webinars are available on our website, so please take a moment and look those up. Thank you very much. Have a good evening.
Thank you so much, Terry. Thanks you for Scott, who have been so amazing and instrumental in getting the Liver Coalition of San Diego off the ground and getting our not-for-profit status approved. My name is Catherine Frenette. I also want to thank Carl, who has been amazing in sponsoring this series, which I think is so important for our patients to really have some education on the disease states that we deal with every single day. So I'm Catherine Frenette. I'm the Medical Director of Liver Transplant here at the Scripps Center for Organ Transplant. I'm also the Director of the Liver and Hepatocellular Cancer Program at the Scripps MD Anderson Cancer Center in La Jolla, California. And I'm going to talk about liver cancer today, which everybody who has any underlying liver disease needs to be aware about. I will say that I have too much to say usually on this topic, so I may end up stopping halfway, part of the way through to answer questions at the end, but I'm happy that you're able to join us tonight. So liver cancer is also, when people say liver cancer, when doctors talk about it, we talk about a really specific type of liver cancer called hepatocellular carcinoma, which is it's cancer that actually starts in the liver. We also call it HCC. We also call it hepatoma. These all mean exactly the same thing. Some people will actually say liver cancer, but they'll say, oh, my mom had liver cancer, but it started in her colon. Well, that's actually not liver cancer. That's metastatic colon cancer. So when we're talking about liver cancer, we're talking about cancer that actually started in the liver. When we name cancer, we name it by the organ where it started, not by the organ where it is now. So that's an important thing if you're going to try to find information or something. about, a problem, you want to think of, make sure you're looking up the right things. So that's really what we're talking about today. So I might, throughout the talk, I might say liver cancer, I might say hepatocellular carcinoma, I might say HCC, and that's really means this liver cancer. So just to give you some information, there's actually multiple primary types of liver cancer, but HCC is really the majority of primary liver cancer, meaning that's starting in the liver. Unfortunately, liver cancers are incredibly common in the world and in the United States. And as of 2018, liver cancer was actually the fourth most common cause of cancer-related death in the world. In the world, the World Health Organization actually estimates that in just 10 years from now, we're going to have 1 million patients a year die from liver cancer. So it really has skyrocketed and is very, very common, and we're going to continue to see more of it. In the US, the death rate from liver cancer has increased by 43% between 2000 and 2016. Now, that doesn't mean people who had liver cancer are dying more. That means the number of people who are dying from liver cancer has increased because we're seeing an increase in liver cancer. You can see on these maps where the incidence, prevalence, and mortality rates are. The US is really right in the middle of the world. Much of the liver cancer in the world is in Asia. As Carl said, hepatitis B is a very common cause of liver cancer. And much of hepatitis B, it's very common in Asia. So we see a lot of liver cancer in Asia, unfortunately. But it is actually increasing significantly in the United States. So when you look at death rates from cancer in the United States, liver is actually one of the few cancers where we're actually seeing an increase in the number of patients dying from cancer. We talk and hear about increasing rates of lung cancer and colon cancer and breast cancer, but even though we're seeing higher rates of those cancers and higher numbers of those cancers, we're actually not seeing as many people die from those cancers. Unfortunately, the rate of liver cancer development is actually outpacing how quickly we're being able to develop new treatments. And so much of liver cancer is actually on the rise, and we're seeing more and more cases every year in the United States. Right now in 2020, it's estimated that we'll have over 40,000 cases of liver cancer diagnosed in the United States. So really a big problem that we're seeing a lot of. So we talk about staging with liver cancer, and I'm going to get more into, why do you have liver cancer and what causes it and why are we seeing more of it? But I really just wanted to show the staging system up front to let you know that, number one, most of liver cancer, most of HCC happens in patients who have underlying liver disease with cirrhosis or sometimes hepatitis B. But when we think about staging for other cancers like colon cancer or breast cancer, it's always, okay, well, what stage are you? And that tells you how much cancer is there. Is it 5 centimeters? Is it 10 centimeters? Is it in the lymph nodes? Is it in the lungs? The liver cancer staging is different. And the reason that it's different is because not only when we're looking at a liver cancer patient, not only do we have to think about how much cancer is there and does it spread and where's it at, but we also have to think about the underlying liver function. And so staging for liver cancer actually doesn't come in as well in a stage 1, stage 2, stage 3, stage 4. We talk about stages A, B, C, or D, because the very first thing that we think of is this person's liver function preserved? Is their liver healthy? Because if we don't have a healthy liver in someone with liver cancer, it's going to be very difficult to treat the liver cancer because it's going to make the liver worse. So just realize that, as a hepatologist, a liver specialist, I end up treating a lot of the liver cancer because so much of what we do is about keeping the liver healthy. And the other webinars in the series that we've had through the Liver Coalition of San Diego will give you more information about how to keep your liver healthy. And I encourage you to go to our website and watch those. So I set this talk up as a frequently asked questions. And I did this really as in thinking about when I was thinking about how to do this talk, I was like, okay, well, what are the most common questions that I get from my patients who come in with liver cancer? What do we have to think about? Well, the first question that I always get is, well, why did I get this? What did I do? What happened? Why do I have liver cancer? So to think about why people get liver cancer, you have to understand why people get cancer in general, but realize that, again, most liver cancer in the United States happens in the setting of cirrhosis. So these are just pictures of your liver, and you can see this nice, healthy red liver here that's nice and smooth. Then when you get infections, whether it's hepatitis C or hepatitis B or other problems with the liver, like too much alcohol or non-alcoholic steatohepatitis or NASH, where we had a frequently asked questions on that one earlier, that then causes inflammation in the liver and chronic hepatitis. You then end up with cirrhosis, which is scar tissue in this liver, this lumpy, bumpy liver. So what happens over the years, anywhere in our body that we get chronic damage to our liver, that where chronic damage is occurring and then healing and then occurring and healing, that's where cancer starts. So if you think about this, if we think about what causes skin cancer, well, it's sun damage, right? It's damage that we get from the sun, you know, and oftentimes it's the damage that we got 50 years ago when we were kids and didn't realize that mom telling us to put on sunscreen was a deal. That causes skin cancer. Just like chronic sun damage causes skin cancer, chronic liver damage causes liver cancer. Chronic lung damage from smoking causes lung cancer. So that's really where this cancer is coming from, is because of this chronic liver damage. Now, the other reason and an important thing to think about this is if you have a person who has a lot of sun damage when they were a kid, and now when they're 50 years old, they start wearing sunscreen and staying out of the sun, their risk of skin cancer doesn't go away, it just gets better, okay? So if you've got somebody with chronic liver disease and chronic liver damage and cirrhosis, and they get rid of their hepatitis C or they stop drinking, that cancer risk doesn't go away all the way. It gets better, but they still had all those years of damage through the years that caused this damage to their liver that could potentially develop cancer. Okay, so it's important to remember that even in patients who may be listening who've had their hep C treated, if they had cirrhosis, they need to think about getting their screening. So risk factors for liver cancer, really anybody who has cirrhosis, we know that causes can cause liver cancer. Also viral hepatitis. Now hepatitis B is a little bit of an interesting virus where you actually don't need cirrhosis with hepatitis B to get liver cancer. With hepatitis B, it actually damages the DNA of the liver cells itself, and that can actually cause cancer without cirrhosis. So hep B is a little bit of a special case. But if you have cirrhosis, well, what are the other risk factors? Well, diabetes is a risk factor. Diabetes can double your risk of liver cancer. Obesity is a risk factor. If you've got hep C cirrhosis and you have obesity, your cancer risk has gone up. So that's a reason that we always talk about keeping a healthy weight. Cigarette smoking, risk factor. Being a man, sorry guys, but being a man is a risk factor. Alcohol use is a risk factor. Ongoing alcohol use on top of something else or just alcoholic liver disease is a risk factor for developing liver cancer. And then iron overload. So I always worry about patients getting too much iron, and that's always something that I check. So that's a risk factor as well. Now, in terms of viral hepatitis, we do know that treating the hepatitis decreases the risk of liver cancer, whether it's hepatitis C or hepatitis B. About 5 years ago, when the hep C drugs were coming out, there was a little bit of a concern that treating the hepatitis C with our new medicines could potentially increase the chance of liver cancer. That's actually been shown to not be true. What we see is that treating viral hepatitis, taking your hep B medicines, or treating and curing your hep C cuts your risk of liver cancer by about 75%. So really, really important to get rid of that virus or keep it under control in order to keep this risk down. Now, what about some things that might be good in terms of decreasing your chance of getting liver cancer? Well, statins. So statins are cholesterol medicines. We call them statins because they all end in statin. Atorvastatin, pravastatin, simvastatin. These are things like Lipitor and Zocor. And these medicines all have a thing on them that says caution if you have liver disease. Well, we've actually found that in patients who take a statin, especially a certain type of statin called a lipophilic or a fat-loving statin, like atorvastatin, lovastatin, or simvastatin, taking that statin decreases your risk of getting liver cancer. So this is something that we're still doing further data or further research on in terms of whether we should be putting everyone on a statin who has chronic liver disease and cirrhosis. But if your doctor wants you on a cholesterol medicine, and you're worried because it says caution with liver disease, talk to your doctor, but realize that long term this medicine can actually help you decrease the chance of getting liver cancer. Now, the other thing that you can do, and I can never do a talk on liver cancer without talking about coffee, but coffee decreases your risk of liver cancer. Coffee is very good for your liver. So there's been a multitude of studies now, but this is just one that shows people who drink coffee, at least 2 cups of coffee a day, their risk of liver cancer is lower, okay? So this is a really interesting thing. We don't 100% know why this is. We know that coffee decreases the risk, but tea does not. So tea drinkers, unfortunately, do not have that benefit. And we also know that decaf also works. It's not the caffeine. Decaf coffee also decreases your risk. It's thought that there's maybe something in the coffee that's an antioxidant for the liver, and that research is ongoing, but coffee is good for your liver. Now, the other thing that is important to realize is the more cups of coffee you drink, the more benefit you get. So people who have 0 to 1 cup are on this top line right here. If you drink 2 or 3 cups of coffee a day, your risk is about in half. But look, if you drink 4 or 5 cups, it's even lower. 6 or 7 cups, even lower. I personally drink about 10 cups a day because I really don't want this. So if you really want to do something yourself, maybe think about adding some coffee to your regimen. Just 2 cups a day will give you a benefit. The Europeans are way ahead of us in this. So this was actually a European liver cancer guideline that came out a couple years ago now that actually says coffee consumption has been shown to decrease the risk of liver cancer in patients with chronic liver disease. And in these patients, coffee consumption should be encouraged. So now in my office, when I'm seeing my patients, I always ask them, are you drinking coffee? And I encourage people to drink coffee to cut that risk down. So some people will, with chronic liver disease, they'll say, I do their scans every 6 months. I'm getting an ultrasound or a CAT scan or an MRI of the liver. And they're going, wait, why do I have to do this every 6 months? Is this really necessary? I mean, gosh, I'm doing a lot of scans. I don't have cancer. Why do I keep getting scans? Well, the reason is because we know, again, chronic liver disease and cirrhosis can cause cancer, and we want to screen you. This is called screening. Just like we get our mammograms every year, just like we get our colonoscopies, screening for cancer. Now, the rate of developing cancer on every 1 scan you get, the rate is pretty low. However, it's a cumulative rate, okay? So this was a study that they looked at patients, about 180 patients with hepatitis C cirrhosis. Now, this study is about 15 years old, so these are in patients that did not have their hep C cured because they tried to get treated and couldn't. But what they did is they watched them for 17 years while we were waiting on new therapies. And what they found is over 17 years, almost 1/3 of these patients developed a liver cancer, okay? So this risk, we have a risk of about 3 to 5% per year for hepatitis C if you have not been treated, but that's cumulative. So the longer you have cirrhosis, the higher the risk of that you're getting liver cancer. We have very clear guidelines on who should be screened for liver cancer, okay? And really what it boils down to is every single person with cirrhosis should get screened, regardless of what your cirrhosis cause is, okay? Even if you've had hepatitis C that's been treated, you need to continue to get screened forever. Again, hepatitis B is a little bit more difficult because it doesn't necessarily have to have cirrhosis to get cancer. So patients with hepatitis B, if you're an Asian man over the age of 40, you need to get screened. Asian women over the age of 50, If you have Hep B and anybody in your family had liver cancer, you need to get screened. And then African or North American Blacks, hepatitis B at any age need to get screened. What we don't know for sure is that younger hepatitis B carriers, we know that they can get cancer, but we don't know if the benefit of surveillance is really there. And then patients who are bridging fibrosis or stage 3 fibrosis, we don't know if those patients should get screened, although many of us will continue to screen those patients, even if they don't have cirrhosis, but especially if they've got risk factors like obesity or diabetes, or they're a man, or they're a smoker. Importantly, the guidelines for hepatitis C says specifically, if you have been cured, you still need to get screened. Okay, so that's really important because we see a lot of people that they get their hepatitis C treated, it's gone, they feel fine, they get busy, life gets in the way, and then they cancel an appointment and never get back in to get their screening. And then now 3 years later, they're presenting back to their doctor and they've got a cancer that they didn't know about. So how do we screen? Well, we do ultrasound. The recommendation is ultrasound and a blood test called an alpha-fetoprotein every 6 months, okay? And this is, again, every 6 months forever. Now realize that what we call the sensitivity, means how many cancers are we actually going to pick up? They're not that great by themselves, okay? So you really have to do these sort of interpreting the data, and you have to keep doing them. If you just do a one time, the sensitivity isn't great. But if we see, okay, your ultrasound has changed or your alpha-fetoprotein is rising, that then says, okay, we need to get more specific imaging like a CAT scan or an MRI. That's what we call cross-sectional imaging. We also know that patients who have really bad livers, you know, your bilirubin is 15 and you have a belly full of ascites, we don't screen those patients anymore, because even if we find a cancer, we're not going to be able to treat it because their liver is too sick. The only difference would be if they're a candidate for transplant, we need to definitely continue to screen them. We do CAT scans or MRIs in patients that we can't get a good ultrasound, or the alpha-fetoprotein is elevated or something like that. And I'm going to talk a little bit more about CAT scans or MRIs, because you have to have what we call multi-phase disease. It's got to have an arterial phase, a portal venous phase, and a delayed phase. And I'll show you what that means. But the reason I bring this up is because if you go you have abdominal pain and you go to the emergency room and they do a CAT scan on your belly, that's not going to be a multi-phase. So that's not going to be adequate. That's not going to count for your 6 months screening, okay? We know that doing screening improves survival, and this is why we do it, because we know that if patients wait and only get their cancer diagnosed and treated once they present with symptoms, their survival is really not great. Nobody lives longer than 4 years, okay? So really, really bad. If patients get surveillance, they actually can get found and treated at a curative stage, and we can have much better survival. So it's really important to do this, because we need to find the cancer when it's small, when it's the size of a golf ball. If you think about things, your liver is about the size of a football, okay? We want to find your cancer when it's the size of a golf ball, and you can hide a lot of golf balls inside footballs and not feel it and not show any lab abnormalities until it's really, really advanced, and now you've got a grapefruit inside of the football. So some of the other serum markers we use are AFP-L3 and then something called DCP, or des-gamma carboxyprothrombin. So I only bring this up so you hear that these are tumor markers. It's a little complicated to get into with our short duration tonight, but these can help us try to figure things out a little bit more clearly, because sometimes the alpha-fetoprotein alone isn't elevated, or it's elevated, but we don't know, is this elevated because of cancer that we can't see, or is this elevated because your liver is inflamed? Because the AFP will also go up if you have liver inflammation, like from hepatitis C, okay? So if you've got ongoing damage going on in your liver because of whatever problem, your AFP can be a little bit elevated just from that. So sometimes we need these other biomarkers or serum markers, blood tests, to tell us what exactly is going on. So Once you get a scan, then based on what we see on the ultrasound or on the alpha-fetoprotein, that tells us what to do next. And we use something called a LI-RADS criteria. And I want to explain a LI-RADS criteria to you because you'll hear us throwing around these terms, and I want you to know what they mean, okay? So if you do your ultrasound, it's normal. We go and repeat it in 6 months. If we do it and there's a mass, oh, there's a lesion that's 10 millimeters or 12 millimeters or something, then we have to go on and do that CAT scan or MRI. And ultrasound alone is not going to give us the diagnosis. So then we look at what's called the LI-RADS criteria. And I'm showing you this table just so that you know that it's a little bit complicated. If I get my scan done and it's done at a small community hospital in the middle of the desert, they're not necessarily going to be looking at liver scans every day, and they're not going to be as used to these criteria as, say, the radiologists at Scripps or UCSD or Sharp or one of the bigger centers where they're looking at these scans every single day. And so oftentimes when I get a scan done outside, I get the pictures. I want to see the pictures because pictures are worth 1,000 words. But we look at these very specific criteria on the CAT scan or the MRI to help us to make the diagnosis of liver cancer, okay? So there's LI-RADS 1, which means we know it's benign. We don't have to worry about it. LI-RADS 2, most likely benign. We don't have to worry too much about it, but we repeat imaging. But really what we got to think about is LI-RADS 3, 4, and 5, and then LI-RADS M, okay? So you'll see if I talk about a LI-RADS 5 lesion, this is definitely HCC. We do not need a biopsy to prove that this is liver cancer, okay? If it's a LI-RADS 4, it's probably HCC, and we don't need a biopsy. Sometimes we'll do a biopsy, sometimes we'll just treat it. LI-RADS 3, that's basically saying, we're not really sure what this is, but we got to keep a really close eye on it. And then LI-RADS M means, well, it looks like cancer, but it doesn't look like HCC. We're not sure what this is. We probably should biopsy it, okay? So if your scan comes back and it says LI-RADS 3, we repeat imaging generally in 3 months because we want to see, is this growing? Is this changing? Does it look like it's turning into something bad, okay? And we'll continue to monitor this for at least a year, if not longer, because some liver cancers are very slow growing and won't change for a few months or a year. If it's a LI-RADS 4, we do what's called a multidisciplinary discussion. That's also called a tumor board. So you may hear your doctor say, well, it's a LI-RADS 4, I'm going to present it at tumor board. And what that basically is 20 to 30 to 40 doctors and nurses and PAs and NPs sitting around a table and looking at scans and discussing cases and figuring out what's the best thing for you. And that's a way that you're basically getting 50 people's brains involved in your care without necessarily having to see 50 different doctors. So it's really, really helpful. Sometimes if it's a LI-RADS 4, we might biopsy it. Sometimes we might say, we don't really want to biopsy it, and I'll talk about biopsy in a little bit. Let's repeat imaging in 3 months and see what it looks like. LI-RADS 5, again, that's liver cancer. We do not need a biopsy to make the diagnosis. We just go ahead and treat you. And then LI-RADS M, again, oftentimes we'll biopsy these LI-RADS M lesions because we're worried about them. They look like cancer. So how good is this? Okay, so if I tell somebody they've got a LI-RADS 3 lesion, what's the chances that this is actually a cancer? Well, it's less than 50-50. It's about 37% of these are actually going to be liver cancer. So you got to continue to get the scans, but many of them turn out to be nothing, okay? LI-RADS 4, it's about 75%. LI-RADS 5, 95%. And then LI-RADS M, 94% of them are cancer, but only 37% are malignant, or 37% are liver cancer. So this is like just a way that we can look at this imaging and give us an idea of how bad are things and how much do we have to worry, and gives you some of the vocabulary that we use. So this is what triple phase imaging looks like, okay, or multi-phase imaging. So this is the cancer right here. It's arterially enhancing is what we call it. So basically what this means is when you get your contrast, this tumor lights up. It lights up like a light bulb. This one over here, you see this, lights up like a light bulb. This is the tumor inside the liver right here. Then later, a little bit later, about 30 seconds later, look at this. It looks dark, okay, on the CAT scan or the MRI. This is called washout, meaning that this tumor is now darker than the background liver, okay? So this tells us almost certainly that this is a liver cancer, and we do not need a biopsy to know that. So a lot of people say to me, well, how can I have liver cancer if I feel fine? Like, I don't understand why you're telling me I have this cancer and now I have to have all this treatment. I feel okay. Well, unfortunately or fortunately, many cancers of the liver present with 0 symptoms. There's no changes on labs. There's no symptoms at all. There really is not a typical presentation. There's not oh, this is how liver cancers always present. It doesn't exist. Sometimes it can present with pain. Sometimes it can present with weight loss or just not feeling well. Sometimes it can present with, well, my liver was better, it was really good, and now it's bad. Now I have ascites, or now I'm jaundiced. So all of these things make me worry about, is there a cancer developing in this liver? The important thing to realize is that the liver, again, it's a big organ and it can hide a lot of things in there. Also, the liver itself doesn't have any nerve endings. It's only the surface of the liver, or the capsule of the liver, that actually has nerve endings that can cause pain. So something inside the liver isn't going to cause any pain until it actually gets into something that has nerve endings. So, I sort of talked about not wanting to do a biopsy. Well, why don't we do a biopsy? I mean, a biopsy should be easy enough, right? Then we'll know for sure. Well, unfortunately, it's not easy and that easy sometimes, and it's got risk, okay? So one of the biggest things that I worry about is what we call tumor tracking, okay? So it happens about 1 in 100, so not super, super common. But what this means is we put the needle in, and when the needle comes out from the biopsy, it drags tumor cells with it, okay? So if you look at this picture right here, this is a patient of mine who had a liver cancer, and it was biopsied by her regular doctor before she came to see me. And it was a curative cancer. I was going to cure her, and she was going to be totally fine, okay? Then about 3 months later, she says, hey, doc, I've got this weird bump on my belly. What is this? So we biopsied this, and this is now liver cancer growing on her abdominal wall, okay? Her tumor tracked cells along the needle when it went in, okay? So this is now a metastatic disease that I can't cure. This cancer has now spread because we put a biopsy needle into it. Okay, so that's a worrisome thing. This right here, this bump, you see this bump that right here, this is in between the liver and the abdominal wall. This is a patient of mine that got a transplant. Again, was biopsied well before his transplant, then was transplanted. This is his new healthy liver, but this tumor was spread by the biopsy that he had had before the transplant. And now he's got recurrent cancer after his transplant because of the biopsy. So we do not want to biopsy something unless we have to, because it could potentially make things worse, okay? The other thing to realize is that there's a really high, what's called false negative rate, meaning you get a biopsy, the biopsy comes back and says, there's no cancer here, and everybody celebrates. Well, but there could still be cancer in there, and that can be as high as 30%, meaning 3 in 10 biopsies can say negative when there's actually cancer. And if you think about it, again, liver, size of a football, deep inside your body, the radiologist is trying to hit something that's pretty small, and your liver moves when it breathes. So it's hard for them to get the needle into exactly the right spot in this moving target, okay? It's also hard for the pathologists for tumors that are what we call well differentiated, meaning that they don't look very different than normal liver cells. So they get the biopsy and they can't really tell for sure, is this a cancer cell or a liver cell, because it looks so similar. So even if the biopsy comes back negative and says no cancer, it's really, really important to continue to get scans, because if that tumor or that lesion is now growing or changing, we may need to rethink a biopsy. Okay, so The other thing that comes up a lot is, well, can I get a transplant if I have cancer? Okay, and that's a really good question. And in fact, transplant is one of the treatments that we use. Okay, so when we think about the different treatment options in somebody that's got liver cancer, the things that we think about are surgical stuff, cutting it out, and that's transplant, or resection, just cutting out a part of the liver that has the cancer. And then there's other things that we can do, like an ablation where we burn it, or a TACE or a Y90. And then there's a lot of systemic therapies now that we're going to briefly go over. Transplant, resection, and ablation are the things that are considered curative, okay? So cure is important. Of course, we want to cure, right? And we know that when you look at survival, if somebody can get a transplant, they are much more likely to survive 5 years or longer than any other treatment that we have for liver cancer. So when I'm thinking about somebody with liver cancer, I want to cure that person. So if I can transplant them, I would. Now, the problem is that we have to be really careful about who we transplant, okay? Because if we try to transplant somebody where the liver has already, or the cancer has already gotten outside of the liver, we're going to make things worse, okay? So when we transplant someone, we have to put them on immune suppression so that they don't reject the new liver. However, the immune system also is really, really important when it comes to controlling cancer. So when we put them on immune suppression, if there's cancer cells hiding in their body somewhere, like it's gotten into the blood vessels or it's gotten into the lung and we didn't see it yet, that cancer is now going to explode and be almost impossible to get under control. So we have to be really careful not to transplant people who are not going to do well. So how do we decide? Well, we use something called the Milan criteria. So this was actually sort of an interesting history lesson, but in the 1980s, when transplant was first happening, they were transplanting anybody with liver cancer, any size, 25-centimeter tumor, great, let's transplant it. Well, what happened was that they would have horrible recurrences where the cancer would come back a month after surgery and just be spread everywhere, and people would do really, really poorly. So then they actually stopped transplanting anyone with liver cancer of any size, even a little tiny 1.5-centimeter tumor, they wouldn't transplant them. So then this guy named Vincent Mazzaferro, who lived in Milan, published this article in the New England Journal of Medicine. It's like the biggest journal that we have in medicine, showing that if somebody gets a liver transplant for liver cancer and is within the Milan criteria, they're going to do really well. So the Milan criteria is if you have one tumor, it has to be less than 5 centimeters. And if you have more than one tumor, you can only have 3 centimeters, and they all have to be less than 3 centimeters, and you have to have less than 3 tumors. No evidence of invasion into the blood vessels, no evidence of spread outside of the liver, and you can get transplanted and do really, really well, okay? So again, this was 1996, so this is 25 years ago now, but what he showed is that people who are within the Milan criteria, they lived just as well as anyone who didn't even have cancer, whereas people outside of the Milan criteria did very poorly. Their survival dropped off significantly, okay? So we now transplant people who are within the Milan criteria. So we have to keep them to within the Milan criteria while they're waiting, and we'll often do other treatments like a TACE or an ablation or radiation or something to keep their cancer in criteria while they're waiting on the list for their turn to get a liver. So the other question that comes up is, well, you're going to make me wait 1.5 years or 2 years or however long, sometimes less, sometimes more. What's the chances that the cancer is going to grow while I'm waiting? Well, if you have to wait 2 years, the chance that your cancer is going to grow and get out of criteria, that's what we call waitlist dropout, it's going to get out of criteria while you're waiting, is about 25%, okay? Now, thankfully, we're able to get most people transplanted within a year, which means less than 20%. And again, doing local therapy while you're waiting improves your chance of being able to stay on the list. So that's why it's really important that we treat people while they're waiting for transplant so we can keep that cancer under control. The other thing that we talk about when it comes to transplant is what we call downstaging, okay? So downstaging is basically saying we're going to do a treatment that's going to make this surgery possible that otherwise we wouldn't be able to. So if you have a cancer that's outside of the Milan criteria, your cancer is 6.1 centimeters instead of 5 centimeters, we used to say, sorry, you're outside of the Milan criteria, let's do other treatment. Now what we have learned is if you have that 6 centimeter tumor and we can treat you with a TACE or a radiation or ablation or something and get it to die where now it's only 2.5 centimeters that's alive, you're now in Milan criteria and we can get you points on the transplant list and we can transplant you, okay? Or you've got 3 tumors, but one of them is greater than 3 centimeters. Well, let's kill one of them and get you within Milan criteria. And if we can keep you there, we can actually get you transplanted and you can do really, really well. Okay, so that's what we're doing now called downstaging. So that's a really important piece that we're doing for many patients where we're being able to offer them this curative treatment. So, okay, well, now we've talked about transplant. Well, what treatments are you going to do? Or if I'm not a transplant candidate, what else do you have? What are other treatments? How do you decide what we're going to do? Well, it's complicated, okay, as you can imagine, as I've already sort of shown you a bunch of complicated stuff. And I sort of think of it like Joe versus the volcano. So we got to treat the cancer and we want to be as aggressive with the cancer as we can, but we also have to protect the patient, right? We have to protect you. So we can't do so much cancer treatment that we're killing the patient and killing the liver while we're killing the cancer. So it's a balance. It's a balance between how much does the cancer need and how much can the patient or the liver tolerate? Because everything that we do to the cancer, we're also doing to this poor little liver. So that might depend on where is the cancer? Where exactly in the liver is the cancer? Is it hanging off the edge or is it smack dab in the middle of it? Is it right next to a big blood vessel? How big is it? How many? What does it look like? Is it gotten into blood vessels? Has it spread outside the liver? And then we look at how much can the patient tolerate. We look at something called performance status. And what that means is, does this patient, are they pretty fit? They're doing their stuff and they're not really having a ton of symptoms, or are they really like not very functional and they get up in the morning and eat breakfast and go sit on the couch and then go back to bed and go back to the couch and don't really do anything else? That's performance status. And somebody who doesn't do very much isn't going to be able to tolerate very much treatment, which is why it's so important to maintain your nutrition and your exercise. Also looking at liver function. So again, I told you at the beginning, the reason hepatologists are involved in this is because everything we're doing, we have to make sure that this patient who has cirrhosis, that liver is going to be healthy enough to tolerate whatever treatment that we're going to give. Okay, so we look at that. We look at also age and nutritional status and what other medical problems they are. So this is that balance, okay? So when we're looking at treatment options, curative treatment options, resection, transplant, ablation, survival, more than 5 years. People do really, really well, okay? That's why we want to always think about curative if we can, okay? TACE, which is chemoembolization, where we're injecting stuff into the tumor itself. Survival is about 3 years or so, sometimes longer, and we're getting better at it. So, we're doing better now than we used to. There's also a lot of systemic medications now. We have a ton of different medicines that we can talk about. And it used to be that this stage C survival was about 6 to 8 months. That used to be what it was. Now we're at about 22 months or more. Okay, so we're doing a lot better. And then people who have really bad livers, really bad performance status, really, they don't do very well at all. So this is sort of the order we think about things: transplant, resection, ablation, TACE, then systemic therapies. But again, it depends on every patient. Every single patient's a little bit different, okay? So thinking about resection, a lot of people, and I'm just going to touch on each of these treatments just in the interest of time. When I think about a resection, one thing we know is that patients' livers that have cirrhosis don't like to be operated on. And what we don't want to do is cut out a cancer and then leave somebody with a liver that is not very healthy, okay? So we actually have to look and say, okay, well, again, what's the performance status of the patient? How healthy are they? What's their comorbidities? What's their liver function? And how much of the liver remnant is there going to be? That's the word that we use, meaning how much liver do we have to cut out to get the cancer out? How much liver are we going to leave left? Is that going to be enough liver for this patient to live? Can't live without your liver. So we have to leave enough of it back in there that you're going to live, okay? We also know that if you have more than one tumor, a resection is not going to do a very good job. So we try really hard not to resect people who've got 2 or 3 tumors because they just don't do as well. It comes back, okay? What we want to see is that the surgery itself is, very well tolerated. People don't die from it. The problem is recurrence. So that's the problem with resection. So transplant recurrence rates, we're talking, about 5 to 10%. Resection, it's 50 to 70%. And part of it is sometimes the cancer itself comes back, but sometimes the cancer itself is cured, but now you develop a new cancer, a second cancer, because the same damage to your liver that caused the first one can cause a second one. So we have to be really careful if someone gets a resection, we have to keep scanning them and watching, okay? So there's pros and cons of resection and transplant, right? Pros for resection, well, resection, you don't have to wait. You don't have to wait for your chance to get a transplant and have that risk that your cancer is going to progress while you're waiting. Okay, so that's great for resection, but we worry about the recurrence, right? And we worry, some people aren't even candidates for resection. Transplant, it's great because you treat the cirrhosis and you treat the cancer and people do really well, but we don't have enough organs, so we can't transplant everyone the day we want them to transplant them. So it's sort of a balance, and it's always a difficult choice sometimes. Now, ablation, I've mentioned ablation a few times. So ablation is basically burning the tumor, okay? So basically what this is, and this shows you a little picture, and there's a couple different ways to do ablation that we label differently, but they're all sort of the same thing. Basically, this needle goes in, it opens up like an umbrella, and it burns the tumor. So you cook it. You basically stick the needle in and cook it. Now, some things we worry about is, again, needle track seeding. So that the radiologist who does it actually burns the track on the way out when they pull the needle out. They pull it out when it's still hot. So that way, if any cells come with it, those cells are burned also. And so we're left with this nice dead spot in the liver. It is a little bit limited by where's the tumor at? Is it next to a giant blood vessel? Is it next to a gallbladder? Is it next to another organ that we don't want to hurt? That might make it difficult. The other thing that it's limited by is how big is it, okay? So when I was trying to explain this to my husband, who's not a doctor, he's like, the size, really? And I said, yeah, he's the cook in the house. So I told him it's like cooking a thick steak versus a thin steak. It's harder to cook a thick steak all the way through. A thin steak, you're going to cook right away. So same thing, it's harder to burn a big tumor than it is a little tumor. So the smaller tumors, less than about 2.5 to 3 centimeters, we do really well. 90% of them, complete control. Bigger ones, much more difficult to get total control just because they're so big, it's hard to kill the whole thing. The other thing that we think about is TACE, and I've mentioned TACE a couple times. So TACE is really interesting, and what it does is it actually takes advantage of the anatomy of the liver. So the liver is the only organ in the body that there are 2 blood supplies going to it. So the liver has 2 blood supplies. It's got the artery, which is this red thing, and then it also has the portal vein, which is the big blue thing that drains all the blood out of our intestines straight into our liver. So 80% of the blood flow to the liver is in the vein and 20% is in the artery. However, when a cancer grows, like this one here, all of the blood to that cancer comes from the artery, 100%. So we use that to our advantage. And what we do is called a TACE, transarterial chemoembolization. So what we do is we put a catheter into this little artery that's in your liver, and we get it as close to the tumor as we can, and we inject stuff straight into the tumor. In TACE, in the example of TACE, it happens to be these little tiny beads, and those beads are soaked in chemotherapy. So the beads go into the tumor, They block off the blood supply, so you get enough beads in there that now you don't have any blood supply to the beads, and then they release chemotherapy over a couple weeks straight into the tumor. So we get really high doses of chemo into the tumor, but almost nothing to the rest of the body. So that's really very useful. This the catheter is put in through the artery in the leg, comes out, you wake up with just a little Band-Aid on your leg. It's really pretty remarkable what we can do. We're pretty good at killing things with the taste. So response rates, how many people actually have the tumors be dead? It's about 30 to 75%. Again, depending on the size of the tumor and what happens and where it's at. The thing to remember, and again, TACE is not curative, okay? So with TACE, we will always see the cancer come back, and we will always have to do more treatment. So this buys us time. So about 80% of people, it buys about 6 months. There's 70% are alive at a year, 50% are alive at 2 years, and about 40% are still alive at 3 years. 30% are alive at 5 years. So this buys us time. And this buys us time to get to a transplant. It buys us time to get to the next treatment, whether that next treatment might be systemic treatment or medicines or new medicines that are coming out. We've had an explosion of new medicines for cancer, including for liver cancer. So even if it only buys us 2 years, 2 years from now, we're going to have better treatments than we do today. So buying time is good. The other thing that we think about locally is called Y90 or yttrium or internal radiation. So this is, again, using the TACE-like procedure where we put a little catheter into the artery feeding, but we, instead of chemotherapy, we inject these little radiation beads. So I show you this picture. This right here is a human hair. So you can imagine how teeny tiny these beads are. So these beads actually go and they lodge into the cancer and they do radiation inside, okay? So this is a way we can give radiation to the cancer without, again, hurting the rest of the body, okay? So I'm going to skip ahead a little bit just because one thing I want to mention is the systemic therapy. And what's really, really important to realize, again, number one, chemotherapy, like you think about chemotherapy where you go in and get stuff put into your veins and all your hair falls out and you're throwing up every day and feel horrible, that does not work for liver cancer, okay? Will not happen. It doesn't work. We actually didn't have anything for drugs that we could use for liver cancer until 2007 when we got sorafenib approved. Then, starting in 2017, we started to have this whole slew of medicine get approved. Lenvatinib, pembrolizumab, nivolumab, regorafenib, cabo, ramucirumab, and then atezolizumab with bevacizumab. Look at all these drugs that we have available. It is absolutely amazing what's happened to systemic treatment for liver cancer in the last 3 years. We have just had an explosion of therapies. And this is why buy-in time is important, because this is going to be really what gets us to the best next place, okay? So as you can imagine, this is really complicated, and multidisciplinary management is really what we talk about when we're talking about what's so important. So all of these different treatments all have their place. And when we're trying to figure out what's right for the patient, every specialist who's involved in the patient has to be involved to really get to the right place for the patient. So that's where this multidisciplinary management comes in, the tumor boards comes in, you know, the primary care doctor, the patient, of course, is the most important part of that team. And it's really a team approach that's going to get us to the very best place for each patient. I will stop there and I'd be happy to take any questions.
Thank you, Dr. Frenette. The first question we have is from someone that was transplanted in 2012 and they had HCC, and then they wanted to know, is there something in the body system that could cause it to reoccur again?
That's a really good question, and I didn't talk about a lot of recurrent after transplant just for time. After transplant, we do see about 5 to 10% of cancers can come back after transplant, okay? Usually that's because the cancer had already gotten out of the liver before we knew it. The problem, and what we see is that oftentimes we don't even know that the cancer's outside of the liver, and it'll pop up a year later or 2 years later or 3 years later. The good thing is we see most people who recur after transplant, it comes back in the first 3 years, and almost everyone it's in the first 5 years. So 5 years after transplant, we pretty much celebrate and say you're cured. So someone who transplanted in 2012, they should be out of the woods.
Excellent. Another question was about someone that has hemochromatosis, and you mentioned increased iron in the blood, who also had hepatitis C and has been cured from the new treatments. How would you define a risk factor with someone that has an unusual both?
Yeah, so we know that hemochromatosis with the iron overload is a significant risk factor. It's great that the hepatitis C is cured because that's now dropped the risk in half, but the hemochromatosis can still be a problem. And it's really important when patients have iron overload with hemochromatosis that they actually get that treated. And we know that if we can get the iron out of the liver with hemochromatosis, treatments like phlebotomy or medications, that can also decrease the risk. However, someone who's had both hepatitis C as well as iron overload, that's somebody that I would definitely be doing surveillance on and scanning them every 6 months.
Okay. I think we have time for one more question, and it deals with COVID and looking at immune suppressants with transplant.
Yeah.
And how has that changed things given this very unique environment that we're in now?
So it is a really unusual environment, and we are learning more and more about this virus every single day. When COVID first happened and it was coming out and we were getting the initial reports from people who were transplant patients, we were finding and hearing that mortality in transplant patients who got infected with COVID was very high. It was about 30%. The updated data said, okay, well, you know what? It's not that high. It's actually getting better. And then we dug a little bit more into the data. And what it seems like, and again, things change, so don't hold me to this a month from now, but what it seems like is that in transplant patients, it's not the immune suppression itself that makes them at risk, it's the comorbidities, which oftentimes is worsened by the immune suppression. So many transplant patients are older, or they're obese, or they're diabetic, or they have high blood pressure, or they've had heart attacks, and all of those things are comorbidities. Those comorbidities actually worsen the risk of COVID more than just being on the immune suppression.
Excellent, thank you. Well, this has been a fantastic hour to spend with you, learning about what patients can do and should know, and you answered a lot of questions, loved your format, and thank you so much for being here, and thank everyone for spending the night with us for this topic. This will be posted, we recorded it, for others that haven't, or if you wanted to share with the family members, you kind of talk about some of these questions and how it's going to impact you and your family. So thank you very much, Dr. Frenette. I just want to mention, as the chair of our Medical Advisory Council, your leadership is just instrumental, and you've shown once again tonight just how fantastic you are and how supportive of the community you are. So thank you.
Thank you so much. It's absolutely my pleasure. Patient education is so important to make sure everyone knows what's going on with their own health and their own bodies. And I want to thank you, Scott and Terry and the board and our sponsors, of course, to let us really bring this education to the community.
Great, thank you. And have a good evening, everyone. Bye now.
Good night.